All right. Hello, everyone. I'm Anna. I'm going to do a recess small talk as well. So we'll start with oh. Is that working? Okay. So case presentation, you're in CCT and your triage nurse comes in saying that you have a hypotensive patient. You go and see the patient. They're alert and oriented ×3, but they have an odd affect. They can't really tell you why they came to the hospital. So you get them in the room, you put them on a monitor and you see the following vital signs: heart rate 58, blood pressure 82/41, satting 95% on room air, and their temperature is 32 degrees Celsius. So you do a quick physical. ABCs are intact. Patient looks pale, some decreased breath sounds at the bilateral bases, belly soft. They have some non-pitting lower extremity edema. And you put the probe on the chest, you see some mild pericardial effusion without any tamponade, good squeeze. IVC is somewhat collapsible, and then there's fine sign on the bilateral bases. So you put 2 large bore IVs and you get some labs. Here are some of your labs. So I'll just let you guys look at it. Everyone's probably looking at the hemoglobin, 3.7. You also see the sodium's 122, glucose is low, little AKI, and then this comes back. TSH 97, T4 0. So I'm going to talk about myxedema coma today. Here are our objectives. I'm going to go a little bit deeper into hypothermia management as well. So here's a very busy slide about the thyroid hormone. We all know the thyroid hormone affects like almost all parts of the body. And here are some of the things that can happen during myxedema coma, but I want to highlight that it is a clinical diagnosis. So people with hypothyroid can have symptoms, but they're in a compensated state until there's like some kind of trigger, like an infection, surgery, bleeding, that puts them in a decompensated state when their organs start to fail. And your thyroid tests, while useful, are not what determines whether the patient is in a compensated or decompensated state. That's your clinical diagnosis. And your findings, here are some of the potential findings you can have in a decompensated state. So cardiovascular wise, you can have bradycardia, as we all know, but you can also get prolonged QT and go into torsades. You can get pericardial effusions or tamponade. And then the most important and a later finding is cardiogenic shock. So we know the thyroid hormone increases inotropy and chronotropy in the heart. And so these patients are going to go into shock because they have no cardiac output. They have no inotropy or chronotropy. So when you reach for your pressors here, you want to make sure that they're going to increase those things, not just the peripheral resistance. So all 3 are important. When I was reading about this, there wasn't a consensus on the best pressor for these patients, kind of varied hospital to hospital. But usually they have to go on multiple pressors. So you can always start with levo, but you may have to add things like epi or even dobutamine. And a lot of the patients will be pressor refractory until you get the steroid and thyroid hormone on board. So that is what the consensus in all the papers are, is that is the best treatment for the shock. Neuro-wise, it's called myxedema coma for a reason, but also it's a little misleading because not all these patients are comatose. A lot of them are just like odd affect, like our patient, a little delirious. There's something also called myxedema madness, and they can even seize. Pulmonary wise, these patients can develop pleural effusions. And then there's also a risk of hypoventilation. They have like decreased respiratory drive centrally as well as muscle weakness. So they may have to be intubated. They may become acidotic, they have like respiratory acidosis, and just be aware that some of them may have macroglossia, which can complicate your intubation if that is what you have to do. Heme-wise, these patients, a lot of them will be like anemic, leukopenic, but importantly, they will have an acquired von Willebrand syndrome. So thyroid hormone affects the coagulation factor synthesis, and it's very common to get an acquired von Willebrand syndrome in these patients. So the management would be DDAVP. The dose is 0.3 micrograms per kilogram of DDAVP. It's tough to diagnose von Willebrand on just labs. So if you have a high suspicion that the patients are bleeding, you can just give the DDAVP prophylactically. Renal wise, most importantly, they're going to have excessive ADH levels. So they're going to have decreased free water clearance and become hyponatremic. You're going to manage this like you would any hyponatremic patients. If it's severe, then you need to get, and they're seizing, then you need to get the hypertonic. But if it's just moderate or mild, focus on getting the thyroid hormone on board, because that's what's going to help. Additionally, you can get AKIs from various things like hypoperfusion, from shock, elevated CK if they're cold, or even like a post, like a retention from decreased bladder motility. And then the patients will become hypoglycemic. So just make sure you're getting either cereal finger sticks or providing some kind of dextrose containing fluid. And once you get the steroid on board, that will also help with this. And then the patients will be cold. So I'm going to go over a little more deeply into hypothermia, like general management, as well as specifically for hypothyroid. So the resuscitation for hypothermia should begin pre-hospital. So first of all, does the patient have pulses? If they do, then you can go to your external rewarming. So we all know the bear hugger. Just a note here, and then there's something called the Arctic Sun too, which is like more expensive, and it's like a water bath type of thing. But just a note here for specifically for hypothyroid, a lot of papers and a lot of clinicians will say to be very wary about aggressively rewarming the patient that is hypothyroid, because it can have vasodilatory effects and can worsen any potential cardiogenic shock or shock that the patient is in. But it's kind of like a clinical decision that you make in real time based on how the patient looks, because you're obviously going to want to rewarm them. If their blood pressure is okay, you can rewarm them and just monitor it. If they're on pressors and their blood pressure is holding, be a little more wary about aggressive rewarming. And then most hospitals have the ability to do inline warming in like high flow nasal cannula, CPAP, BiPAP, or vents in intubated patients. The lungs have a huge surface area and you lose a lot of heat through the lungs, is a really good way to rewarm a patient. And then if they do not have pulses, like I said, this should begin pre-hospital, and EMS should know to transfer the pulseless cold patient to like an ECMO capable center, because that is the mainstay of resuscitating the patient. VA ECMO or cardiopulmonary bypass is like been shown to be the best method to resuscitate a patient who's cold and pulseless. However, we obviously don't have this capability, so we have to know what else we can do. You go to your ACLS algorithm, but think about the patient. This patient is not metabolizing anything. They're not really circulating anything. So you can push like 1 or 2 rounds of epi, but just be aware that this patient isn't circulating. So the more epi you push in, when they do start circulating, it's going to be like toxic to them. Once it hits their heart, it's going to cause tachyarrhythmias and negative outcomes. And then shocking them isn't going to do much either if they're cold. So your mainstay of resuscitation is going to be really aggressive, active rewarming. And you can do this by doing thoracic lavage, which can increase your temperature, your core temperature by 3 to 6 degrees Celsius per hour. There's two methods. One is you insert two chest tubes, one anteriorly directed, one posteriorly directed. And then you always want to choose the left pleura if you can to bathe the myocardium. And then you infuse warmed crystalloid fluid to 42 degrees Celsius. You infuse it into the anteriorly directed tube. And then it's kind of like bathing, irrigating the lung in the warm fluid, and then it's draining from the posteriorly directed tube. And then you can also just insert one chest tube if you're unable to do two. And then you infuse 300 to 500 cc's of warmed fluid, clamp it for 15 minutes, and then drain it. You have to monitor this very closely because if there's any concern for like pulmonary laceration, I mean, if you were just pumping on their chest, like you have to be really wary not to cause like a tension pneumothorax. And then there's bladder irrigation, which is similar. If you have a 3-way Foley catheter, you can do the irrigation method and draining method. And then if you have only a normal Foley, you can just infuse, clamp, and drain. All right, so the mainstay, like I've been mentioning, to treat Myxedema Coma is giving stress dose steroids and levothyroxine. So hydrocort 100 milligrams IV Q8 as stress dose steroids. Giving thyroid hormone without steroids can precipitate adrenal crisis. So this is really important to get the steroids in the patient. And then levothyroxine is the inactivated form of the thyroid hormone. The dose is 4 micrograms per kilogram. It's usually like you start with 200 if they're like frail or elderly. 250 is like a pretty standard dose. You can go up to 400. This is going to take a while to have an effect on the patient because it needs to become activated. And that happens in the periphery. And there are some like, it makes sense that there's decreased conversion of T4 to T3 in Myxedema Coma. So there is something liothyronine T3 that you can give. It's kind of a moot point for us. We don't have it available in IV form at Kings County, but it has been shown at very low doses, like 5 to 20 micrograms, to turn like a severely hypotensive cold patient around if nothing else is working. But it has a really high risk of arrhythmias, so it's used like pretty judiciously. And then even if you're just have a suspicion of hypothyroid being the culprit of hypothermia, giving T4 at a lower dose, like 200, most studies, most papers I read, it has the biggest effect is just like warming the core temperature. So it's okay to give. Just watch for any tachyarrhythmias. And then in addition to giving to hormones, the T4 and putting these patients on pressors, fluid resuscitating them, it's important to identify the underlying trigger. So putting antibiotics on board, things like that is also an important part of resuscitating them. So for our case, you always want to consult endocrine. This is like one of the few endocrine emergencies that you are consulting endocrine from the ED for. So we gave the patient steroids and T4 after consulting our endocrine colleagues. We transfused the patient. We warmed the patient, and these patients are going to the ICU. So he was admitted to the ICU. He had a lower GI bleed that was slow. That was the trigger. And then after a couple of days of resuscitation, he turned around and was downgraded and discharged. Here's sources, and that's it.